So Ian is the customer relations manager. He says just for UK and Europe, but actually he's global, and he's my friend. And Paul's going to talk also from the perspective of the international collaboration on cancer reporting, and I'm going to leave it to you to structure the topic.
This should be fun. I was going to say, so originally this session was going to be focused on, what I want to talk about is a bit about SNOMED International, a bit about what we're doing in Europe, particularly in the context of a number of things that have been discussed with the introductory talks, and then really look at the activities, one of which is why Paul's here, is the work that we're doing with the ICCR. So a bit of an overview, a bit about what we're doing in Europe, particularly focusing on where, or a view of where SNOMED fits into the EHDS. And then obviously that link to clinical delivery. And one of the things which struck me about the initial introductory presentations, there is a focus on collecting quality data, but as Charles and I know, as we go and present to clinicians, there is also almost a fundamental step of data. Quality data is what we should be aiming for, but there's also a practical step of just getting digital data that people can read and people can share. So I'm preaching to the converted here, but there is a reason why this slide is here. So there's a bit about what's SNOMED CT. Well, we all know what it is. It's a big, it's a big clinical terminology. It's important that it maps to many other standards. So one of the things which SNOMED is aspiring to do, I guess, and moving forwards, is to really be a terminology integrator. So I've been doing a number of presentations over the last couple of days, and one of the things which came up was a discussion with Odyssey, which I'm assuming a large number of you will be aware of. But Odyssey essentially uses SNOMED as a terminology integrator. So if you're doing research in the Odyssey community, essentially whatever data terminology you use locally, the query that you run is essentially transforming that data into SNOMED so that you can then share those results in a meaningful way with other people around the globe, not just around Europe. So the whole terminology integrator bit is important, particularly in the context of where Europe is going. It's used in more than 80 countries globally. We've been growing for a long time, and some of us here have been involved in SNOMED for longer than we care to remember. It's got to the stage actually that I think my family think that SNOMED is ingrained within me, a bit like a stick of rock. So have we been successful? Well, I'm not going to give you my history, but I've been involved in SNOMED and certainly this organisation of SNOMED from right back in the start in 2007. Not necessarily as a member of staff, but involved from the UK perspective. So when we started the organisation, we're a small but perfectly formed organisation. So we had 7 or 8 members. It was kind of good. We got together every, twice a year. It was a bit like a club, really. It worked pretty well. But we've grown, and the reason this is important, particularly in the context of Europe, is if you look at the EU states, so you have 27 EU member states at the moment, there's 22 of those which are already SNOMED International member countries. The one kind of outlier, if you like, but who are actually using SNOMED currently is Italy. So Italy are doing a very large pilot focused on cancer synoptic reporting, and we're going to be having some discussions while we hear about extending that pilot beyond the cancer synoptic reporting. We've also got those kind of, in Europe we have the hangers-on, if you like, so the Norways, the Switzerlands, the Icelands, the Andorras, and us in the UK. So it's important, you know, one in terms of we now have a lot of countries that are committed to use SNOMED, but also in the context, if you look at this moving forwards with some of the European projects, it means that a lot of the data that's been recorded and collected at the national level will be SNOMED data. And trying to move that forwards in terms of making that data available, in terms of really focusing on the quality, but also the things you can do with SNOMED going beyond just counting. So this is, yeah, hands up, this is my view based on what I do and what I see. I think if you look at where SNOMED sits in the context of the EHDS today, there are a couple of things which are kind of blatantly obvious. So, you know, in terms of the My Health at EU, the initial focus of My Health at EU was patient summary and patient exchange of patient summaries. So within the value set that supports that implementation, the current use of SNOMED uses the IPS and the global patient set, the free set that Don referred to earlier. So we're already using SNOMED as part of this. But at the moment, like I said, the focus is patient summaries. With one of the slides that Constantine showed is where essentially the HDS is going. So you're looking at other areas such as radiology, such as laboratory results, and hospital discharge. So the scope, if you like, of the terminology is bigger than is currently in the IPS. And we'll come back to that about what we're doing about that. And part of that is reflected by really what SNOMED is included at the moment within the Master Value Catalogue, although a lot of the governance structures moving forwards will change with the EHSDS board and various other things that are moving through. We're also, which is what we've been doing for the last 2 days, we're also looking at supporting the European EHR exchange format and looking really at where SNOMED fits in with that and how it fits in with the standards and various other developments linked to that. So that's where we are today. But if you look at where we're going in the future, so one of the things which Constantine referred to is this whole idea of moving forward with health data at EU, looking at the secondary use of data and looking at data being available for research. And, you know, increasingly now, the big driver is making, you know, having data available for analysis. To do that, you need data being available. So one of the things which certainly the discussions we've had, the global we, if you like, is looking at where we can really support the collection of SNOMED data within member countries and really how we engage clinicians to do that, engage essentially governments to do that through whatever mandation or approaches they want to do to encourage clinicians to record that data. Really, we're looking at, we already have a number of projects, if you like, on a global scale, looking at large-scale data analysis. And certainly the lessons from those will feed into what we do and how we support the HDS going forwards. Our own tooling, so all the tooling which SNOMED International develops, we make available as open source. The reason why that's important, there are a number of things related to, particularly to the ontological structure of SNOMED, where we support tooling which would help in some of the analysis and research undertaken by the HDS, and really go, which is kind of where Charles was going from with what we do in the UK, going beyond simply the counting of data, if you like, which you do with ICD-10 or any of the other classifications. So really look at leveraging the ontological basis of SNOMED to get the most out of that data. But I go back to what I said originally, unless you have the data in the first place, the ontological side of it is kind of irrelevant in some ways. So I said I'd come back to this. So the Master Value Catalogue, like I said, originally stored only the GPS, so only the global patient set. That's problematic in the sense of where the HDS is going, where the various specifications are going. So there are really only two options. One is that we take the extended scope of all those specifications and extend the global patient set. So essentially extend the definition of what the international patient summary is. You're on a bit of moving sands there. So is it a patient summary or is it a patient record if you're going down that far? The other approach really was driven by trying to maximise the benefits for SNOMED member countries within Europe, but by doing that within the restrictions of the SNOMED licence, essentially. So one of the things that we did last year is we made some fundamental changes to the affiliate licence, in the sense that previously you signed up to the SNOMED licence and you're allowed to use all of SNOMED. That's where it started, that's where it ended. The changes which we made last year in the affiliate licence essentially allow you as a SNOMED user to send SNOMED concept IDs and descriptions to any other system globally, irrespective of whether or not it's licensed as a SNOMED user system or not. So we took that logic and essentially implanted that in the approach to the master value catalogue. So what we're doing with the master value catalogue going forwards is allowing the master value catalogue to define any of the value sets it uses, to take any SNOMED concepts or descriptions from the international release. This doesn't mean that they're publishing SNOMED CT in the master value catalogue, but it does mean that you'll have a broader range of coverage. The reason that's important then goes back to what I said originally about really getting people to use SNOMED and collect SNOMED data. And if you think about the areas which you're looking at in terms of the specifications moving forward in Europe, any digital system will generate huge amounts of data based on the back of laboratory and radiology, along with things like the drugs. I think with pharmacy is really covers about close to 70 or 80% of any digital data. So having it available for these purposes, I think, will be a benefit for all the SNOMED members within Europe. It's obviously a benefit for us as SNOMED International, but also moving forwards with a lot of those developments where we're going with the European health data space, particularly in terms of supporting the research. Now, I said I'd make a link, so it's a tenuous link, but it's a link. So I have two roles, one of which is covering Europe, the other one is covering clinical engagement, which is where Paul comes in. So we have a commitment to clinical engagement, and I'm not going to read it, but the vision's on there, you can see what we do. In practice, what that means is that we put a huge emphasis on the importance of clinical input into SNOMED. So SNOMED is a clinical terminology. Medical clinical practice isn't static, it changes over time, and SNOMED has to reflect that in terms of its content. The only way to do that is to talk to clinicians and getting them to work with us to develop SNOMED. Otherwise, we essentially become outdated over time. And so we need Paul and his counterparts, not just Paul, I hasten to add. The way we do that, so we have a number of clinical groups that we've set up, either clinical reference groups which are ongoing, or clinical project groups which we set up as task and finish groups. We also do similar to this. I spend a lot of my time on stage talking about SNOMED in various forms. So we do a lot of clinical outreach, either to large conferences or particularly that Charles and I do with one of our colleagues, Jane Miller. We'll go and talk to various clinical groups in different countries. The big bit then, which is where the tenuous link comes in, if you like, to what Paul's doing, we also have a number of clinical collaborations. So what those are formal agreements with other clinical organisations, really to work on developing that content, if you like. So a bit about content, but also a bit about supporting implementation. So through some derivative products, they may be reference sets, they may be maps, we're really moving that forwards so we can support the clinical communities to implement SNOMED. I'm going to stop there. You can, if you want to talk to me, most of you know me, or just email me, that's fine. But I'm going to hand over to Paul now.
Well, thank you very much, first of all, for the organization to squeeze me in, because it was at the last moment that I asked to get some moments to talk about our initiative. And I must say, even before I'm starting, it's already evolving this morning with new elements, but I will come to that. So, first of all, I want to here promote the initiative what we have, the collaboration between SNOMED International and ICCR. So for the people who are not familiar with the ICCR, it's an international collaboration of cancer reporting, and it aims to improve the outcome of cancer patients by standardized pathology reporting. They do that to make international data sets for different organs. So what is actually a standard report, pathology report? Standardization structured reporting, also known, I think, more in literature as synoptic reporting, is a clinical documentation method in which a standardized reporting structure helps to produce more complete, consistent, accurate, and variable medical records. And that can also be for radiology or for surgery. Standardized structured reporting standardizes also how the data is collected, transmitted, stored, received, and shared between the clinical information systems. So I think this is very important to look at this definition. So why is this initiative? First of all, there is a mutual benefits, and we saw that already in the previous talks that we can help each other, and we are just in a small part of, for the medical part, pathology is rather small, but we can help here, and we can use the data for the data elements from the ICCR templates for the training for SNOMED International. So that is the benefit on their side, and it will also directly promote it. On the other hand, it will help countries when they're starting to implement synoptic reporting, and that's not something simple to do, to help them, to this community, that they already have a reference set. And it is not mandatory to use, but it is very interesting to see if you're going to start, and that's the same with the data set of the ICCR, that you already have a high-level evidence data set and already combined with SNOMED bindings. And it will promote, of course, also the interoperability, not only in your nation, but also international, as in the European health data space, of course. So how did it start? This is a little bit before my time, but what I caught up was that it started first as a collaboration between the data steering committee from the ICCR and the authors from the data sets. So they make the data sets, and the data sets are from large pathology communities like the CAP, RCPath, RCPA, and the ESP, so the European Society of Pathology, and they make those data sets. But somewhere it discontinued. So who's at this moment involved in the discussion with this? Of course, Ian and Jean, and from the ICCR, Tina and Kieran, and I just had noticed this morning that Ian, so it goes very fast, that it also will be a formal discussion on the member forum discussion board, and it will be implemented by the co-chair. So there's already promoting, also on LinkedIn, we saw a lot of people already promoting this. So those people, they will take care, let's say, over the whole procedures, what be needed and which way to follow. So at this moment, there are two groups who are involved in standard structured reporting or synoptic reporting. And that is the SHRIC, that's the Structured Reporting Implementation Committee from the ICCR. That's a committee that makes guidelines for low and middle income countries to implement synoptic reporting or standard structured reporting in a region or in a country. And that is needed because when pathologists want to start, they look through the oculaires. So they have a small view, they look very detailed, but to implement synoptic reporting, it asks much more in your organization, also on a national level. So we are helping those countries, but also helping countries with high income to see if that they get all the questions addressed during these procedures. Next to that, there is also the group, of course, from the clinical project group for synoptic reporting, where Scott Campbell is the chair. I think most of you know him, of course. And we already made 1,000 new concepts for solid tumors, so that's already done. And we are now starting with immunochemistry, so we're starting a little bit going further. But we also saw that it is possible to join, because we strive both the same goal. And I think with the combination of SNOMED CT and the data sets, that this could be the way forward. So at this moment, there is a sort of, a committee started with a few people. We gather once 2 weeks, and then we hope that this committee will be formalized in the future. So in this committee now, there are people from the clinical organization like Scott Campbell. George Birdsong is the chair of the SHRIC. And then you see a list of people who are here, some of them in both committees and some are just in this committee. And most important also is the last persons that we will attract when we are talking about data sets. They are very specific. So we hope that this group can make progress to put those data sets combined with the SNOMED combinings. So what to be done? Well, here you see an example. This is a small part of the data sets. You can find the data set at the ICCR website. They are free to see. And what we're doing here is you have a question of the operation procedure. You see the questions there. On the left side is the questions that is on the data set. And what we are trying to do is make a questionnaire from the SNOMED CT code, an answer in the SNOMED CT code. So that binding will then be later published. If everything will go forward, then it will be published also by the ICCR. These templates are already in the blue book, so in the WHO tumor classification book. So it would be nice also if we're going that far that also the SNOMED codes will be in the blue books. So what's next? Well, we started already, and actually as a sort of group who are just fanatics to know which way to go. I see one of the fanatics are here in the room. So we say, okay, let's just put out a letter and see what it will bring. Let's see if we can say to the people from the SNOMED organizations, from the countries, from hey, we want to join together, we want to make the forces together, and we want to ask you to support this, if you want to support this initiative. So I sent this letter to 33 countries. And I must say, the first country came back was in 10 seconds, that was South Korea, but maybe because they do the expo this year, that could be the case, I don't know, but it was very interesting. We had some interesting discussions also with some countries, say, okay, what do you mean, and what is it mandatory, are we constricted if we're going to use it? No, this is not the case. We only want to provide this and put this available for the pathology community. So, this letter is out. I understand that also this morning that Paul Wright from the UK asked Ian also to put this letter on the forum board, if it's correct. So that because not everybody of the, I didn't have all the addresses, so I sent it to where it was possible and asked for the forum members and the chairs and co-chairs from, please send it to them. So I don't know if it also reached to all the people. So we hope that with the forum that will be possible. So what did we ask? We asked in the letter, so you will be seeing the letter later on the board. We asked to confirm the support for not only maintaining but also for the initial filling of the ICCR templates, the data set, the SNOMED bindings. And if you agree that we allow the distribution of SNOMED technology with the ICCR data. I think if you would agree with this, it would be a huge step forward. Because if it will come in the blue books, it will be, of course, very interesting for countries when they start saying, why should we reinvent the wheel if it's already there and it is maintained? So, who already signed? We have now already 7 countries, and this morning New Zealand was also there, so that's a new one. Just gave 2 hours ago. So here, and we have discussion in the Netherlands. We have discussion in Luxembourg at this moment running, and also understand from Paul Wright that they really support this idea, but they want to do it through the member forum, and I think that would be amazing. So the last step is for us, through that member forum, if there is a positive result for this, I can't even remember that it won't be, but if it would be the case, then the question is if it can be formalized, this committee, by the board of members of SNOMED and the board of directors of the ICCR. So if you want to have more information, because I didn't got that much time, but I'm glad I got some time. If you want to have more information on depth on this, use my email and just ask what you want. Thank you very much.
Fantastic, Paul. Really, really encouraging. So, I open it again to the floor for questions. There's a very practical proposition here. I can't quite remember how many you've got, 8 out of 47 member countries. There must be a few here who want to say, I'll sign up now, or tell me a bit more and I'll sign up tomorrow. So let's hear it from you. Well, it's all heads down. So, for those of you who haven't been following the initiative led by Scott Campbell and Paul and indeed others, it has been, I think, one of the sort of miracles of SNOMED actually to see a very, very determined use of the terminology in a very precise area of medicine, which is producing clinical reports that are readable by human beings, meaningful to computers because they're coded underneath, and can be used by patients in their portable records, whatever that is. Now, one of the things I come across a lot, I think, in talking with colleagues about sharing data with patients is they go, whew, you mean they're going to read my report? They're going to read my language and so on? And I think one of the things that synoptic reports do is to standardize that so that the patient isn't faced with the flowery language of an individual who then is embarrassed to share it because it's too flowery or too difficult to understand. This standardizes and simplifies it. It doesn't mean the patient can understand a word that's been said, but it does mean that they can use Google Blaster or any other form of tool to uncover what that means for them. And that is one of the really big challenges for all of us, which is to turn this data into something that a patient can turn into an answer for their life chances. And I think this is one of the most important bits of work that SNOMED is currently doing. So I hope that's given you enough time to think of some questions. Here we go. There's a microphone just coming.
Yeah, my name is Kingling Balin. I'm from the Swedish NRC for SNOMED. Actually, I really support your initiatives, really, Paul and also Scott. Because in the past, we noticed that when pathologists write the reports or dictate the reports, there's a lot of variability, and as Don mentioned, and this information can get lost. And these reports are often the basis for which patients get their treatment and follow-up. So if we have generated a bad report, these patients will suffer. And on top of that, we find that a lot of qualities registers, they get their information from this kind of reports. So by structuring these reports and using SNOMED CT, you could easily also, I would say easily, but it's not easy in practice, but the idea, the logic is to be able to transform the information captured by such reports into registers, which will be meaningful for researchers, for secondary use. So it's actually it plays a very central role, and certainly I do really support what you say, Charles, that it is really an important area.
Thank you. Thank you very much, and a very valuable comment on the secondary use, as you say. Yes, here we go. A man from Skåne.
The man is not from Skåne. The man nowadays is from Antwerp. My name is Stefan Dubois. I'm a practicing pathologist, involved with Paul in very different ways. Won't go into that for the moment. Paul, some of the last comments that were given by Charles about the readability of reports. I know that there's an initiative going on in the Netherlands about increasing the readability for patients. Could you give a comment on that, please?
Yes, I can, and Charles should know that because I did a presentation in Atlanta about that. So one of the benefits is when you use SNOMED CT on the background. So in the Netherlands, where we use standardized structured reporting, the pathologist doesn't see anything about the SNOMED coding behind. So that is one of the, for the daily care, he doesn't or she doesn't care. So it has a lot of use, but not, let's say, for communication between. But the initiative, and the initiative lies with the government and with NICTIS, is that the SNOMED code can also be used to make patient-friendly descriptions and terms. So most important is that before you, because it's your data as a patient, so when you get a blood result and you see that creatinine is behind, outside the reference, it doesn't say much. But if you read in plain text that you have metastasis of adenocarcinoma of the colon, that comes in, right? So before that you're going to dig a hole, or are you going to go to the graveyard already, or coming with questions, etc., it will lead there to patient-friendly terms on a B1, B2 level, B1 level, to explain what this means, and that you can make some adequate question to your clinicians later on. So this is a perfect example what you can use with SNOMED CT. So we are trying to do that with NICTIS in the pilot for bowel cancer screening program. Because that means that a lot of people in the Netherlands is involved, and it's been used in every hospital. So this is going to be in the coming years, but this is a perfect example of what you can do also with SNOMED CT.
Yeah, thanks very much for that, and absolutely right, that some of that translation into either things that patients can read, or indeed other physicians can read in a different language, gives you the opportunities in using these the structured terminology. So, any other questions or comments? Ian, have you got some on Zoom?
I have one on Zoom, which I'll answer in person rather than typing it. There's two questions, but they're actually linked. So the first one is, does the sender of the data know if any given SNOMED concept is likely to be understood by the receiver? That's not to do with the SNOMED code, that's more to do with the system that's sending it. So although we loosely talk about sending SNOMED codes, the reality is that it's in an envelope, if you like. So, whether that envelope be a HL7 file message, whether it's CDA, whether it's version 2, but it's still in an envelope. So the envelope, or the details in the envelope, will identify that it's a SNOMED code. We then provide either, you can look up individual codes on the browser if you wanted to, but we provide a lookup service, which we host to enable any system receiving a SNOMED code, irrespective of whether you're a SNOMED system or not, to actually understand what it is. So, not to my knowledge, there isn't any reason why you would think that a receiver system couldn't understand the SNOMED code, unless there are other things going on. The final question is kind of an interesting one. So, when I talked about what we're doing with the master value catalogue, I'd said, and meant, so I didn't say by accident, that we were focusing on content within the international release. The reason for that is in the label, if you like, is the fact that the content in the international release is designed for international purposes. One of the questions I've had on here is, does the SNOMED usage policy also apply to national supplements and extensions? So the answer is, if you're following the letter of the law, if you like, the answer to that question is yes. If you're looking at the practical implementations of it linked to interoperability and what you're trying to do, then the answer is no. So the idea, I used to work for the UK National Release Centre, so I was one of the SNOMED authors that used to create things in the UK release. So if I think about some of the procedural administrative codes which are in the UK extension, I wouldn't want to send them anywhere else for two reasons. One, people they wouldn't mean anything. So if you're talking about things that relate to specific forms in the UK, you either don't have them anywhere else, in which case they'd be meaningless codes anyway, or more importantly, if you did, so if you use the acronym for that code, but in a different country it meant something else, I'd argue that you're risking the interoperability implementation, if you like. So the focus around the usage really is around the international release, and should be. If there's content, as we do for anything, if there's content within national extensions or local extensions which are of international usage, then there is a process that we have to essentially move that content or promote it, if you like, into the international release. But I don't think it's quite a free-for-all of any SNOMED code from anywhere being used for anything. I think there are dangers going down that route. There'd be dragons there, if you like.
Thanks, Ian. Just looking around once more. There's a question over there. Sorry, could you put your hand up again? So,
Yes, thank you. Thank you, Paul. Thank you, Ian. My name is Koen van Gol from the Netherlands, Dutch National Institute for Public Health and the Environment. I was wondering, Paul, could you give us an outlook on what ICCR would mean for the national and international cancer registrations, and would they support this initiative? Thank you.
Oh, yeah. Well, thank you very much for your question. Well, if we look at the Dutch situation, I think this is quite simple because everything is centralized for pathology, and all the synoptic reports or standard structure reports are created by Palga with the work with the expert groups of the Dutch Pathology Society. If we look at the cancer registry in the Netherlands, ICCR, but there is also an international data set for the cancer registry, and that is actually very limited. I must say, because if you want to look at the incidents, etc., then you don't need that granularity what you have at synoptic reporting. For instance, give you an example, if we use the breast protocol, we have more than 14 questions where you can say something about positivity of the lymph nodes. And the cancer registry only wants to know how many positive lymph nodes you have. So what we do is then we make them in our national protocol on the backside. We say, okay, we group them to one and you get one answer. So it is also one-on-one. Very important with this is that your quality of, is it too long? If I'm on a roll, I'm a roll. So that means that the quality also from your cancer registry will be enormously enhanced, because that means that the integrity of the data is done by the specialist and it's already sent in one-to-one, and you say you only have to take this number, you don't have to look at all those 14 parts. Those 14 parts are very interesting for research, secondary use, right. So, and there is also something what we call GDPR, that say, and you have to have what is your binding? You can't ask as a cancer registry to say, okay, I want to have all the information. Okay, but are you entitled to? No. So that is one of the most important things. So what we do, and I think this could be a very good use case for other countries, if you're going to start with this, talk with your stakeholders. One of the stakeholders, what we do also in Belgium, where we're trying to set this up, is talk with the cancer registry. What do they need? Can you go from granularity to gross? And then give them the information what they need electronically. And I must say, in the Netherlands, we send now more than 300 synoptic reports per year to different registries, so with no data managers in between, so the data is much more integral. So it works, but from granularity to growth is doable, the other way around, not.
Thanks very much for that, Paul, and we're going to wrap up now.